Right, so welcome everyone to the November Liverpool Dementia and Ageing Research Forum. It's a pleasure to be joined by Professor Ann-Marie Towers, who is a Professor of Social Care Research at the University of Kent. And today we will be hearing about a specific tool that she's working with, the ASCOT tool on social care, and specifically to look at improving quality of life for older adults. During this talk, if you want to engage with us on social media, feel free to use the hashtag Liverpool Dementia as always. But without further ado, Anne-Marie, if you would like to share your slides, and we're really excited to hear your talk.
Thank you so much, Clarissa. Thanks, everybody. Right, let's see if I can do this correctly. Hopefully you can all see that. Okay.
Yeah.
Good. Okay, I will just make sure that I can click on the right thing on my side. Okay, lovely. Thank you so much for having me. It's a real privilege to talk to you today. I will make my way through the presentation, but hopefully there'll be time for questions at the end. So without further ado, I will get going. So I'm here to talk today about capturing the impact of social care on older people's quality of life. And I will talk a little bit about dementia specifically, so people who might be living with dementia, but I'm focusing more broadly because social care obviously impacts a lot of people. So I'm going to start with why. Why does impact matter? And I thought when I was preparing this presentation, I thought I'd just have a look at the day's headlines the other day. And this is just headlines that were released on one day last week. So if you have a look at these, I think it really demonstrates the fact that social care is really in not a very good state at the moment. And we are, as we speak, the Chancellor is giving his autumn budget, and we await the findings of that to find out what the budget cuts are likely to be, or whether there will be any more investment. But I think it's important to note that everything that I say today is within this context of a system that is under pressure. So there are currently 1.37 million requests for support by older people in England. That's taken from the year 2021 to 2022. And I think one of the things that I wanted to note is that despite the rhetoric that we hear a lot on the news and in political arena around hospital discharge and social care being so critical for hospital discharge, only 1 in 5 of those requests for social care support for older people are related to hospital discharge. The vast majority of people who are requesting support from social care are living in their own homes already and are in need and asking for these assessments. But part of that broader context is that the number of people actually receiving care is falling year on year. And that's because, unlike the NHS, unlike healthcare, social care is subject to both means testing, so it depends how much money you have as to whether you will be given state-funded social care, but also eligibility criteria, because they have a finite pot and they have essentially experienced cuts, real-time cuts to funding over the last sort of decade or so. And so the way they're responding to that as a local authority or as commissioners is to tighten up those eligibility criteria so that the people who are most in need get given this publicly funded care and support. So you've got this kind of number of requests going up, number of people getting care going down, which, as you can imagine, is putting a lot of strain on the informal care and the voluntary care system, who are picking up the load. And you're getting a situation where a lot of people are trying to cope on their own and basically living with what we would call unmet needs, so needs that are not being met by anyone. And one of the other big problems for the sector is around recruitment and retention. And I think it would be amiss of me to talk about social care today and the impact of social care without recognising the wider workforce problems. So if we have a look here, I've stolen this graph from Skills for Care, who are the workforce organisation for social care, and the King's Fund, who have published this on their website. So as you will have heard the Chancellor say, no doubt in the news, overall unemployment has fallen in our country. And you can see that more people are employed than ever before. But look at the light grey line. look at the dark grey line, sorry, for social care vacancy rates. Can you see how, particularly since 2021, this has gone up considerably? It may only look like a few percentage points, but it's a notable increase. So this is the vacancy rate in the workforce for social care. So the point I'm trying to make here is that people, although unemployment is going down, vacancy rates for social care positions are going up. So people are leaving the sector and they're going to work elsewhere. And this is a real problem for the sector, who are trying to meet people's needs. They can't meet people's needs if they don't have the workforce in place to do that. So why is quality of life in particular important to be looking at in this wider context of problems? You might argue, well, surely we should just be looking at basic care. If we can't meet basic care, why are we even worrying about quality of life? Some people might say. I think it comes back to what is the basic aim of social care. The aim of social care is to maintain or improve people's quality of life. That's the whole point of this service. It's also an incredibly good indicator of care quality. And we know from consecutive years of research that it's highly valued by the public. If you ask a member of the public about social care, they think it's meant there to meet people's needs. It's the basic things about getting people washed, dressed, making sure they've got food to eat, but it's also about improving their quality of life and making sure that they have social needs met and going beyond that kind of basic healthcare need. It's also incredibly important to the workforce. So I told you that people are leaving social care and the vacancy rates are really high. Well, if you ask anybody who works in the care workforce why they got into social care, what motivates them to work in this sector, it usually comes down to the fact that they want to help people, they want to improve their lives. So actually capturing the impact of services on people's quality of life is also incredibly important to the workforce. And if we can demonstrate that their roles are making a difference to people's lives, it might encourage them to stay within this setting. And certainly having a job where you feel like you're making a difference is something that the workforce have told us again and again is really important, and is a partly one of the reasons that people leave, is when they start to feel that those values that they hold around wanting to help people are no longer supported by the environment. So they no longer feel that they're making a difference because of successive cuts or because they don't have the time to care that they want in their role. So I think quality of life is important for lots of things. Yet, and this is, I think, really key, it is not routinely collected to inform either direct care, so things like care planning, decision-making by policymakers. So during COVID, we had no information about people's quality of life that could be set against the models on things like infection and disease. So we didn't have that counterbalance. Okay, this might help stop the spread of disease, but how does it impact people's quality of life? So we had no data that we could draw on for that. And it's also not routinely used when people measure quality. So really, really fundamental things. Yet there is a tool out there that could do this. So I'm going to talk a bit today about the Adult Social Care Outcomes Toolkit, long name, I call it the ASCOT. This is a quality of life measure that was designed specifically to be sensitive to the impact of social care. So it doesn't just look at the kind of broad quality of life that any of us might talk about on a day-to-day. It looks at the aspects of people's quality of life that are impacted by social care. And the reason that's important is because if you've got the right domains, it means that you can start to look at, well, if I change this or I improve that about a service, does it improve quality of life? And if you've got sensitive domains, that's where you are able to kind of measure or capture that impact. The good thing about ASCOT is that it cuts across different social care client groups and settings. So, for example, we've got measures that work for older people, adults with intellectual disabilities and autism, physical and sensory disabilities and mental health. It can be used whether people receive care in their own homes, housing with care, supported living, or in care homes. And it's been rigorously developed and tested. It was launched in 2012, and since then it's been used all around the world. So it's been used in all these different countries, translated into many different languages. And throughout that, we've been able to demonstrate that the measure's properties, which means that it's valid, it's feasible, and it works in different countries and in different settings, which means if we had this data routinely collected, we would be in a really good position to start making international comparisons. So I've said that the ASCOT measures work across different client groups. One of the reasons that it does so is because we have different methods for collecting this data. So we have the kind of, if you think about quality of life and how it's measured normally, some of you may have completed quality of life questionnaires in the past yourselves. The normal way of completing quality of life measures is interview or self-completion questionnaire. You get something in the post that you fill out. That's not very accessible for a lot of people that are using social care. A lot of people using social care have health needs or cognitive needs that mean they need a little bit more support than that. So, for example, in care homes, we have a mixed methods approach that relies on, yes, talking to people about their own experiences and their own perspectives, but also collects important quality of life data through things like observations of everyday care and everyday life in care homes, but also talks to staff and family members about their views. So about collecting that evidence in different ways to fill in the gaps that we might not be able to get from the residents themselves. We have an easy read tool, which was co-designed with people with adults with intellectual disabilities and autism, and that's available to download on our website. We also have a proxy measure, which is a kind of last resort. So when you can't get people's opinions in other ways because maybe their needs have got so great that they can't engage with any of those other methods, then as a last resort, we can get a perspective on their quality of life from their family members, their informal carers, or perhaps a care worker who knows them well. And we've also got different measures now for using it in the kind of assessment, review and care planning. So if you're a care provider and you want to use it, we have a method for you to be able to integrate it into that kind of routine data collection. We also have measures for informal carers. So if you're somebody who cares for somebody who uses social care, it's very likely that the services that are being put in place are also having an impact on your quality of life. And to measure the true impact of services, we think it's important to go beyond just looking at the person receiving care, but also that whole dyadic experience. So the person who is providing that family or informal care, whether that's a friend, a neighbour, a son, a daughter, or a spouse. And this informal carer measure has also started to be used in an assessment and review way. So how can we capture what services would be needed for an informal carer to support them and enable them to continue in that caring role, and how could we use this tool to both assess their needs and review the impact of services on their quality of life over time. And finally, we've got a new measure that will be launched in 2024, which is capturing the impact of care work on the workforce. And I'll talk a little bit about that at the end. So for the most of the talk today, I want to focus on the person who is receiving or using social care services and their quality of life domains, because otherwise we'll be too much to cover in one talk. So have a look at this pyramid. I've ordered the quality of life domains deliberately in this way to reflect what we call Maslow's hierarchy of needs. So there are 8 domains of quality of life measured by the ASCOT. Remember, they are all designed to be sensitive to social care. And if you have a look at the bottom of the pyramid, those are those basic domains that we would expect as a bare minimum services to be meeting. So this is their quality of life around their food and drink, personal cleanliness and comfort, their accommodation. If they live in their own home, they might have someone coming in to help them keep their home clean and tidy, their safety. And then we move up to the domains that I would often describe as adding quality to your life. So once those basic needs are met, then it's about, are you able to stay socially engaged? Occupation, that sounds funny, like we mean jobs, but actually by that we mean meaningful occupation. So are you able to spend your time doing things you value and enjoy? And for some people that will be work, or it may be voluntary work. And for others that will be about hobbies, faith activities and so on. And control over daily life. So do you feel that you are able to make choices in your everyday life? Do you feel you're able to determine when your care arrives, who provides that care for you, if you've got preferences around that, and how you spend your time? It affects every single one of those domains: control over daily life. And finally, at the very top of the pyramid is dignity. And in ASCOT, dignity has a very specific meaning. It means the way in which the people who are providing that care, the paid workers, if you like, how they treat you and how that makes you feel. Are you treated with dignity and respect? And how does that make you feel? So those are the 8 domains going up to that peak of the pyramid, starting with the basic, going up to what we call higher order domains, and with dignity topping it all off. And these are the aspects of quality of life that all those ASCOT measures look at for people who are using services. Now, because the gold standard for quality of life is that you would ask a person, you know, what's your quality of life like in this area? And you ask them to respond. We have 4 different response options for each of those, 1 question and 4 response options for each of those domains. And these questions basically relate to what we call outcome states. So in every case, they follow a pattern. The top answer is always the ideal state. So that would indicate that the person's wishes and preferences are being met. So not just it's okay, but it's exactly how they want it to be. So you think about the personalization agenda, wanting to go beyond just meeting people's needs. Then the second response option will always be that, okay, mustn't grumble, it's meeting my needs, but maybe not as personalized as I would like. And then the third option down reflects some unmet needs, so it's starting to affect their quality of life. And the bottom option, which we would never see, but we'd never want to see, but sometimes we do see, sadly, is high unmet needs, which is where their needs they're not being met, so to the extent that it will have an effect on either their physical health, if you think of something like safety or food and drink, or maybe a psychological health or mental health, if you think about things like social participation. So these are conceptualized as these basic response options. I'll show you an example in a minute. And essentially the person would choose which option they feel best suits their own situation. So I'm going to show you a basic domain, and then I'm going to show you one of the higher order domains, just so that you get a feel for the measure. So this is food and drink. It's one of those basic domains at the bottom of the pyramid. Thinking about the food and drink you get, which of the following best describes your situation? This is the ideal state. I get all the food and drink I like when I want. This is that okay, your needs are met, but maybe not your preferences. I get adequate food and drink at okay times. Then starting to affect your quality of life. I don't always get adequate or timely food and drink. I'm really starting to be serious and have a health impact. I don't get adequate or timely food and drink, and I think there is a risk to my health. So we're really spelling it out there that it's starting to be a risk to you. Let's compare this with social participation. So thinking about how much contact you have with the people you like. You notice we put the people you like. And the reason for that is there's a big difference, isn't there, between being surrounded by people and being actually spending time with the people you like on your quality of life. And remember, this isn't just about a tick box exercise. This is about providing something that is meaningful for that person. So which of the following statements best describes your situation? And again, I'll just take you through those levels so that you can see they all follow the same pattern. I have as much social contact as I want with the people I like. I have adequate social contact with people. We've dropped the I like. So it's starting to get to, well, I see people, but it's that preference is being lost at the second level. And then as we move down to it's affecting your quality of life, I have some contact with people, but not enough. And then the worst option, I have little social contact with people and I feel socially isolated. So hopefully that word socially isolated, you can see it starting to have an impact on somebody's well-being, or going beyond just it's not affecting my quality of life, it's starting to have a psychological impact on you. So if you can imagine, you have those 8 domains, you have those questions for every single domain, one of those questions and the responses for each domain. These together, these questions can be used to derive 3 different types of scores in the ASCOT. We call these current social care related quality of life, expected social care related quality of life, and social care related quality of life gain. Now that all sounds very technical and complicated, but I'm going to explain what that means and demonstrate how that information can be used. So essentially what we talk about when we say current is, what is their situation like now? Imagine you completed that questionnaire for yourself. That would be your current social care related quality of life today when we're asking you the questions. Now, if you are a service provider, for example, and you wanted to use it as a baseline assessment, then that could be done at assessment before you put your service in place. And this is their baseline. But often, actually, it's asked when people already have services in place, just to get a snapshot of how well services are meeting their current needs. All of the ASCOT tools that I mentioned earlier measure this. And there are usually 9 questions, 1 per domain, and then we have, which is 8, and then we have a filter question, which I'm not going to go into today, but that's why there are 9 questions. But that's quite short, quite easy for people to complete. But the problem with only asking those current social care related quality of life questions is that, yes, it tells you about how they feel now, but what it doesn't help you unpick is the impact of services. So let's imagine a situation where a person is living at home with their spouse or their partner, and the spouse or partner is providing some informal support during the day, but also they have someone who comes in twice a day and helps with maybe getting up, getting washed and dressed, and maybe towards the end of the day getting changed and ready for bed. But the rest of the day there are other people coming and going that are not to do with the services, but who are helping and supporting the person receiving care. How do you unpick what is helping, what is impacting? How do you measure the impact of that home care service that's being paid for on that person's quality of life? Lots of different things could be affecting their quality of life. So how do we attribute it to the service? So the first thing is that you need to have domains of quality of life that are sensitive to the impact of services, which we know we've got. We've done lots of testing over a decade of work to prove that. But the second is that you kind of have to think, well, what would their situation be if they didn't have that home care service coming in, so that we can compare or we can estimate the difference that the service is making. We call that, in technical terms, the counterfactual. So essentially what I mean by that is, what would that person's life be like if they didn't have that home care service coming in that example? Oftentimes we do this in research through things like randomized controlled trials, where we will have a control group and we will have a group getting the service and we'll compare them. Sometimes we do it by looking at before and after the service to get a comparison. But a lot of times, if you're a care provider and you're trying to demonstrate your impact, then those sorts of things are not going to be practical. You need a more practical way of estimating the impact of your service on the lives of the people you're supporting. What we do with ASCOT is that we ask people to estimate it. We ask them to think about what their life would be like if they didn't have care. And this gives us a bit of a comparison point, basically, in that person's own view. We call this expected quality of life. And it assumes that no other help steps in, and it's obviously highly correlated to the person's ability to meet their own needs. Because if you say to somebody, imagine you didn't have this care and support that we're providing, what would your quality of life be like then? They would have to think about, okay, well, if I didn't have that help, what would I be able to meet? How would I be able to meet my own needs? So it's highly correlated with the person's own ability to care for themselves. So here's an example. I've shown you the current food and drink question already, so I'm not going to spend too long on this, but this is the current question. And then what we would do if we were interested in the impact is that we would then ask this question. So imagine that you didn't have the support and services that you get from, and this is really important to define. So if you were a home care provider, or you were a care home or something like this, and you wanted to check the impact of your service, then that's where you would put the name of the service or whatever the person uses that you do now and no other help stepped in. Which of the following would then best describe your situation? I would get all the food and drink I like when I want. I would get adequate food and drink at okay times. I wouldn't get adequate or timely food and drink. And the bottom one, I wouldn't get adequately or timely food and drink, and there would be a risk to my health. So you can see that it mirrors the current questions, but it's about that counterfactual. It's about them estimating the impact or estimating what their life would be like if they didn't have that care and support. And this sounds like it would be a really difficult thing for people to do, but actually, when we did all the testing around this, what we found is that actually people who are receiving social care find this really easy to do, because particularly in a situation whereby you rely on that care and support coming in to get you up and about and living your life, then it's always going to be at the back of your mind. What if they don't turn up? What if there's a problem today and no one comes? So actually, it's a very real situation for people to have to think about how they would cope and how their life would be affected if they didn't have that care and support. So it's something that people feel quite strongly about and can tell you. So by having both their current quality of life and this estimated expected quality of life, it enables us to estimate the impact of the service, and it's best shown visually. So I'm going to show you a little chart here. So this is based on care home residents in England from research that we've conducted at the University of Kent. And here, if you have a look on the outside, I've shown some of the ASCOT domains, and you can see on this side of as you're looking at it, the right side of the graph, you can see the basic domains, and on the left side you can see some of those higher order domains. And if you look at the blue shaded area, this is, remember, a big group of people, not one person. If you look at the blue shaded area, this shows you how well care homes in England are meeting people's quality of life in these domains. Now, the further out towards the edge that blue shaded area goes, the better people's quality of life in that area. So we've got really good current quality of life, accommodation cleanliness. So care homes are basically being kept clean. Well, that's not a surprise, is it? We have a domestic team that come into most care homes and will keep that environment clean and tidy. Personal care. So yeah, we know that there's a dedicated workforce on site in a care home that are providing, keeping people clean, washed, dressed, comfortable. And overall, people's quality of life is good in this aspect. Not quite so high for meals. So there may be some issues here around food and drink, but quite high for safety. So basically, by and large, people are in that environment because there would have been concerns about their safety, and now they're being kept safe. But look at the left side of the graph. We can see here that where care homes are not doing such a great job at meeting people's quality of life is in those higher order domains. So particularly around occupation, the quality of life is nowhere near as good. So keeping people engaged in activities, how they spend their days in a care home, that's definitely a quality of life need. And less so social and uncontrolled, but still nowhere near as high as those basic domains. So just by looking at current, the blue shaded area, we get a snapshot, a quick way of looking and seeing people's quality of life in care homes across these ASCOT domains. But what's really interesting is that if we have a look at the green shaded area in the middle, we can see just how much care homes are doing for people who are living there. So what we know is that by the time you move into a care home in England, it is very likely that you need 24-hour care and support, otherwise you wouldn't be there. Every effort is being made to keep people in their own homes for as long as possible. So without the support and care being provided by the care home, look how poor people's quality of life would be. So this tells us the difference between the green shaded area and the outer edge of the blue shaded area shows the impact. So the first thing that we can say is care homes are having a huge positive impact on people's quality of life. These are people who need care and whose quality of life is being improved by having care. But we can also see that care homes are having less impact, still some impact, but less impact on those higher order domains of control over daily life, occupation, and social participation. So a nice graphical way of demonstrating the impact of services on people's quality of life. And in home care, for example, that would look really different. What we would expect to see in home care is that the green shaded area in the middle is bigger because people's needs are not as great for care. So their expected quality of life. So although we might say that the blue shaded area may be bigger in some areas, for example, maybe in social, or for occupation for some services, what we would also expect to see is that the impact would be less, which is exactly what you would expect given the cost of services when you're comparing. So a really useful tool, I think, for providers, but also for commissioners and other people who are wanting to benchmark and compare the impact of services that they might be funding. So given that we've got these tools and given the scope and the possibility for their use, why is this data not being routinely collected in a way that can inform decision making? I think that's something really important to reflect on. So what are the barriers to use? I think the first thing to note is that social care is a fragmented system. So although we collect ASCOT data in the national user experience surveys that are sent out by every local authority in the country, they're only sent to a sample of the people who are receiving publicly funded social care, because those are the people that local authorities know about. We know that many people in England and across the UK are funding their own social care, and they are invisible to local authorities. So we really ideally need to go through social care providers to collect this data if we really want to capture everybody and not just those who are publicly funded. And that's quite difficult to do because we have a fragmented system in social care with lots of different providers, and ultimately it's up to those providers to decide what information they want to routinely collect and how, to a certain extent. There is also the issue about access. So some social care users, particularly I mentioned earlier in care homes, but also other people living in their own homes increasingly have cognitive impairment and higher needs. They are going to really struggle to complete measures like this. And so actually we need to start thinking about what are the alternative methods? How else do we collect this data that doesn't rely on a questionnaire being sent out in the post that somebody can't complete and return in that kind of traditional way of collecting quality of life data? We also need to think carefully about the burden of data collection on care providers. We already know that care providers, particularly care homes, collect so much data for different purposes, and they actually are really buckling under the strain of all of this different data they're having to collect. So we need to make sure that if we ask people to collect data, it is, one, it can be directly relevant to care. So there's a point in them collecting it, but also that it's integrated into care systems such as e-care records to make it easier for providers to collect and reduces the burden of data collection. So I'm going to just end by presenting a couple of solutions. So just so that I'm not just presenting all of the issues. So we are trying to address these the issue of burden of data collection. The first way that we're doing this is through the Dementia study. I've got a link there to the website. This has been a huge program of work over 4.5 years, piloting piloting a minimum data set for care homes, but within that we've been specifically looking at different quality of life measures, ASCOT being one of them, and we've embedded these quality of life measures into electronic care records. So care homes are increasingly using these digital social care records or electronic care records instead of these traditional paper records. And by embedding quality of life into those e-care records, it makes it much quicker and easier for them to be able to record the data quickly and get initially some feedback from the system about that quality of life data. As part of Dementia, what we're also doing is linking the data that's being held about residents in their e-care records with data that's held about them in other places. So data is held about residents in GP records, by hospitals, in emergency, like ambulance data. There's a heck of a lot of data out there, local authorities, but it's all in different places, and at the moment you can't link any of it up. So that's what we're doing in that study, is looking at how we can collect this data in a way that reduces that data burden. And we're in the process of analysing that data now. Because we wanted to reduce the burden of data collection, we included in the Dementia study the ASCOT proxy, which, if you remember from the start of my talk, is the one that I said was our last resort. So it's the quick and easy one, in the sense that a family member or a member of staff can complete it on the person's behalf, knowing that most care home residents wouldn't be able to complete a very structured questionnaire like this. So this is an example of the ASCOT proxy. It's exactly the same questions, but worded as though you're filling it out for somebody else, basically. And you'll see the other thing to note here is that we have 2 columns. So the first column is where we ask the person completing it on behalf of somebody to give their own view. So let's pretend I'm a care worker or a nurse working in a care home, and I'm caring for a particular resident. Then I would say, in my opinion, I think they've got as much control of their daily life as they want. But actually, I think Mrs. Smith would say this. So you give both your own view of that person's quality of life and how you think that person would answer. And by having the 2 perspectives, it helps the person answering this to delineate their own view from what they think the person's view would be. And we found in testing that this is actually really useful to have both boxes alongside each other. I'm showing you how it would look in paper. It's been integrated into these electronic systems to make it a bit easier and for them to complete. We've started talking to staff about the value of this approach to data collection, using the digital care record softwares, but also specifically collecting quality of life data about residents in this way. And I'm just giving a couple of quotes because we're still in the analysis stage. But what's been really interesting is just how quickly staff have adapted to using digital care record software, and the value that they can see with it, that it's going to save them time, hopefully avoid as much duplication. So I think it is the way that well, it certainly is the way that it will go forward in the future, but it isn't just being top down driven by policy. I think increasingly it's being bottom up driven by care homes, managers and staff who can really see the value that if they can spend less time recording data and duplicating data across paper records, then it's more time to do what they really got into the job for, which is spend time with people and provide care for people. And then we've got the second quote there, which is around the quality of life assessments. And I think important here that this quote just picks up on the fact that until we started this pilot, there were no routine data collection around quality of life going on. Staff would say they know about residents' quality of life because they have relationships with residents, and sometimes they might tick little boxes on their system which say, I've gone in and I've got Mary dressed today and she's in a good mood, and they tick a smiley face. But that is really different because that's about mood. That's really different from measuring in a really rigorous way and in a way that's comparable across services somebody's quality of life. So it's about staff starting to see the value of, it's not just another assessment, it actually gets to the crux of why we started to work in care in the first place. Now, I'm very conscious that what I've just described is very much about staff making judgments about people's quality of life, and it to a certain extent excludes the resident, although many care homes of course talk to residents before they completed those measures. But I think a more inclusive way of going about this, and perhaps more useful way for providers, is to integrate quality of life into care planning. We've designed something around this for the ASCOT in conjunction, in partnership with care providers. And it's being used in Australia and it's being used in Sweden. And we've got some funding to start piloting it in England as well, which is around, we call it a circle of care approach. So it's around those ASCOT domains, those quality of life domains, but it becomes a conversation, a care planning conversation between the person. And that could be somebody living in their own home, it could be somebody living in a care home, it doesn't matter, or supported living, the person themselves using services, and formal carer if they've got one and that's appropriate, and a member of staff who works for the service, and they sit together and they have an open conversation around how is your life going in these aspects of your quality of life. And they use the information that comes out of that to inform a care plan. So it becomes part of continuous quality improvement. And I think where this is really useful, certainly in the countries that we've already been working with, is that it demonstrates to the regulator and to commissioners, funders, that you are committed as an organisation to continuous quality improvement. You're not frightened of having these conversations. But it really importantly gives staff permission to focus on quality of life. So rather than just focus on the process of care, the tasks of care, it's also about giving staff permission to measure, capture and derive a whole care plan around improving that person's quality of life, which, as I said at the start, is one of the things that really keeps staff motivated to work in this job. So just to flag that this is ongoing, and that it's part of a national ARC priority theme, and there will be some piloting around this in 2024 and 2025. So hopefully we will start getting some data around this in the UK, not just in Australia and Sweden, which is where it seems to have taken off. So just to summarise before I end, I feel quite strongly that it's never been a more important time to start capturing the impact of social care on people's quality of life. ASCOT, I think, offers a suitable tool. It's feasible to use, and it's been validated across many different research studies and in different languages. Historically, there have been many barriers to collecting routine data around quality of life, and that has led to the fact that there is absolutely no evidence routinely available to really inform decision making, quality ratings, or direct care. And I think this is a real problem. And ultimately, until measures like ASCOT are integrated into routine practice, this is going to continue to be a problem. I also think that we need to start thinking beyond just measuring the impact of care on the person using care, but also start thinking about what I'm calling the triad of care. So you've got the person using care at the top, but also thinking about, well, what feeds into their quality of life? It would be amiss of us not to think about the informal carer, which we've already got measures for, but also thinking more broadly about the workforce. We have a huge workforce problem in this country, and we need to start thinking about the impact of care work on their quality of life as well. And when we start seeing this as a whole, as a triad, I think that's when we're really going to start changing and improving things and seeing better outcomes for people who are using and drawing on these services. Okay, so there's some contact details for me, but I'm going to stop sharing my screen, Clarissa, so that we can take questions.
Super, thank you so much, Anne-Marie. Really interesting, and much nicer to hear about it than just reading a paper about it for us academics. But it's also great to have it more broken down into non-academic language. So that's really important. We're now taking questions. If anyone has any questions or statements or thoughts or comments, please feel free to just add them to the chat. Just chat it in there as well. But whilst we're waiting for some questions, hopefully, I think it's really valuable to hear about the wider issues of social care data collection from you, Anne-Marie. So not just quality of life and quality of care, etc., but generally, as you were saying, in the pandemic, we didn't really have a go-to database like hospital episode statistics or GP data. We don't have that to see how it impacted on people's social care and well-being, but also the highlighting of the staff and workforce retention. So there are options there then to use and work with ASCOT with the social care workforce, right?
Yeah, so I think this has been a gap for a long time because we do these studies, we do these evaluations, and we come up with the same sorts of conclusions, which is, the level of staffing matters. If you think about what determines a quality service, it will be things like the pay for staff, the number of staff if you're looking in care homes, say staff to resident ratios. It will be things like the skills, are the staff trained? But there's always this sort of wider kind of noise in the data. There's kind of this bit that we can't explain. And I think we're amiss if we ignore the fact that our workforce are people. And if they're coming to work and they're feeling stressed and they're feeling like their values and the reason they got into care are being eroded, they feel like how many domiciliary care workers have been interviewed who have said, well, I don't have enough time. I run between this service and that service, and I want to do so much more, but I can't because I've got to get on to the next person. And so I felt really strongly that we needed a measure that captured the impact of working in care on workers' work-related quality of life. And that's now been piloted with just over 7,000 members of the workforce through the new Adult Social Care Workforce Survey that Department of Health and Social Care have commissioned. And we're in the process of analysing it now to see how well it performs. But the emerging findings look really promising. And so if all goes according to plan, what we hope is to be able to make this available, this measure, next year. so that if you are conducting research or doing evaluations, or if you're a provider or an organisation employing staff, you will have a mechanism to start looking at the state of your workforce, and how you might be able to improve working conditions, and hopefully that will lead to better retention.
That's fantastic, and 7,000 is not a small number, so well done on doing that.
Yeah, thank you. That was Ipsos Mori who supported that. They were fantastic. Yeah.
Brilliant. We've got a question from Claire. She's saying she's really interested in whether this tool has been used by occupational therapists as part of care planning, OT assessments and interventions.
No, it hasn't, Claire, but I think this has been one of the major barriers, is trying to get it used in practice. So it was used by some local authorities from early on around assessment and review, but that was used by, care managers, people who are assessing people. But to my knowledge, it's not being used currently by any occupational therapists.
But maybe there's a branch out there for the tool.
Yeah, it has
Possibly.
been used in research around things like adaptations to people's homes and things like that. So Philip Whitehead, who's a researcher academic who was an occupational therapist himself, he's used it in RCTs to look at the impact of bathing adaptations on people's quality of life. And it was sensitive to that. He was able to demonstrate the impact on people's quality of life. So I think there's huge scope.
Great. Any other questions? So I think you might know this person actually. So Laura's asking, so great presentation. Have you found that the care home sector has embraced ASCOT, or are they wary of assessing quality of life because residents may highlight weaknesses in their provision?
Well, I think so. The problem that we've had in England hasn't necessarily been about that. It's been more about bandwidth of care providers to engage with it. So we've even got as far as having UK care homes trained, and then the number of staff attending the training has dropped off, and they've said, we're sorry, we've lost our manager, we're short-staffed. So it's been around the pressures that the workforce has been under to learn something new. But they often come to us saying, this is what we want. We want to be able to demonstrate the impact on quality of life, and quality of life really matters. So it's overcoming some of those kind of the barriers to uptake, I think, at the moment are around capacity of the workforce. And they're just overwhelmed, which is why in DATCHA we tried to make it as light touch as possible, put it in the e-care records, make it accessible, make it a 5-minute tool that staff can quickly complete. Now, I don't think that's ideal. I think ideally you'd put it as part of a care planning conversation, but that's a step on. But almost the foot in the door was, could we get it just being collected, so that it almost starts to become part of that, oh, I can see that there's a point in collecting and measuring this, and starting to demonstrate its value. In Sweden and in Australia, where it is used by care homes, it's been welcomed. Some staff initially in Australia found it a bit threatening. So, and then we had some ceiling effects. So we had a situation whereby when we first started using it in Australia, we kept seeing that quality of life was brilliant across the board. And we had to do some work with them and make them understand that this wasn't going to be used as a stick to beat them with. So it's about how you present this information. And no, we don't expect quality of life to be brilliant, all the time, but it's what you do with that information that matters. And being able to show that journey over time, rather than treat it as a single snapshot that a care home would be judged by, I think is really important.
Yep, and that's fantastic, the international branching out of it as well, especially in the Australian system, which is a little bit different, isn't it, compared to ours? That's great. We have a query from Emma, because you mentioned with the ASCOT tool, you can collect data from the person themselves, but also from a caregiver. So let's take dementia into consideration. Do you at times compare responses from someone living with dementia with caregiver assessments, and is there any variation?
Yeah, so where we've done it in care, that's why in care homes we use a mixed methods approach. So I think in care homes, if you're doing, there's two different questions here. I think there's one, it's about, are you using it for research and evaluation, or are you using it as a provider because you want to work with that person and maybe you know, care plan around it and things like that. So my answer would be different. So if you're using it in research, then I would strongly recommend that you use either our mixed methods toolkit, which does look at collecting information in different ways. And we don't ask a care home resident with advanced dementia to complete a questionnaire because they can't. You'd be setting them up to fail. It's more about having a open, or if you want to use technical terms, qualitative interview. But I would say it's more like having a chat, a conversation about their quality of life, and they will engage at whatever level they can. But what you don't tend to get is a tick in the box, like I showed you from those conversations, right? So if you're using it as a researcher, what you also need to do is supplement that by talking to family, doing an interview with family, doing an interview with staff. And we have a whole training course on how you collate that evidence that you've collected through those different sources and use that to inform ratings of quality of life. So that it's a really different approach. If you're a care provider, that's why I think the circle of care is so important, so that you're not ignoring the person's own view, but you're also acknowledging that sometimes that person may get confused or may not be, maybe remembering something that happened at some point in their past rather than the situation as it is now. And that does happen. And I think it's important to acknowledge that. And therefore, the circle of care interview involves a relative, if that's appropriate, but also someone like a key worker, a member of staff who works with that person, knows that person really well, and it's part of that ongoing improvement, ongoing care plan. So it's not so threatening, hopefully, if you do have to identify that there are issues.
Great, fantastic. Thank you so much. I don't think there are any more questions. There's a couple of comments, which you could read through afterwards as well, Anne-Marie, if you fancy. And we've got unpaid carers here as well in the audience, which is nice. So thank you to those joining. And yes, thank you so much, Anne-Marie. I'm going to give you a virtual clap because I love that function. So join me if you all want to do that. Thank you, Anne-Marie.
Thank you. Thank you so much for having me.
No problem. It's been lovely to hear about it, and a little bit different to last time we heard about rarer dementia. So now we hear about the social care angle and how to record data and the pitfalls that there still are, but also to highlight more of a focus on the social care workforce, which I think many people might not think about so much. So that's fantastic. Now, unfortunately, due to Eventbrite now charging us money for people to be registering for events, I haven't been able to set up the next forum on Eventbrite yet. I will sort this out on a non-cost version, but the next event will take place on the 31st of January from 11 a.m. to 12, featuring one of our postdocs here at Liverpool, Dr. Megan Polden, there she is, and also one of our interns who's working for the Brain Charity. So the focus will be on music interventions in dementia, and we'll hear about Music Makes Us and Megan's research in that field. So you will get an email soon to register for it. I just have to figure out how. But thank you all so much. Okay, thank you, everyone.